And here we go. Welcome everybody to The Big Idea. I'm Dr. Jeffrey Hanna. Today, I'm going to be doing a case review for a gentleman who came in experiencing many years of concussion symptoms. And do forgive me, I'm having to hold my microphone a little bit closer because I'm in an environment where there's just unfortunately a lot of background noise, but I want to get this content out here because I want to illustrate, not just for this gentleman, but also for people who maybe are experiencing an old concussion, an old whiplash injury, problems like that, about some of the small factors that can be contributing to the ongoing issue. So what I'm going to show you are actually a few of the fellow's images to show you that he doesn't have signs of overt pathology. There's no broken bones, there's no crazy amounts of swelling, there's no tumors, there's no nothing like that, but there are a combination of a whole bunch of little things that are all contributing, I believe, to what he has going on. And this is often the case with people when they're dealing with these kinds of issues. There's not just one thing, and it's going to need a multi-team approach to get the best kind of outcomes. So I do hope you enjoy this video. If you don't currently subscribe to the channel, please do make sure that you click and like. That way other people who are looking for this information are able to find it, and also share this with your friends and family if you think it's going to be benefit for them. Let's go ahead, jump into it. Okay, I need to give you a little bit of backstory for this fellow. This is a fit, healthy man, about 40 years old, who was involved in a severe knock on the head some years ago. Short of it is car door, or the back of the car, the trunk, came down on the top of his head and immediately feeling off, but has not sought any treatment until just recently. This was over 5 years ago. And he's had neck pain, he's had some issues in the head, and they seem to come and go, mostly able to manage. But he was out walking around just a few months ago, and he stepped off of a curb. Now, it wasn't just a little curb, it was actually a pretty sizable curb. Didn't see it was there, came down on his heel and felt his neck go down into that kind of a position like that. Now, by itself, you wouldn't think that that would be enough to really aggravate things. But as I'm going to show you on his films, that kind of action, unfortunately, was just the wrong thing, where it's compressed and it's made a whole bunch of little things all combined much worse. So let's have a look and I'll show you what we see in his films. All right, we're going to start with a series of x-rays, and these are the exact same images, but what I've done is I've annotated them in two different types of ways. So illustrate, we've got the face right here, and we've got the global curve of the neck like that. And at a quick glance, the global curve of his neck doesn't look too terribly bad. I don't see horrific amounts of degenerative arthritis. There is some going on right here between C3 and C4, but I'm going to come back to that. What I want to illustrate for you, though, is what this fellow has really are a combination of different things with his normal anatomy that, unfortunately, because of the injuries he's had, make things much worse. We all have different bone structure on the outside and also on the inside. As a result, sometimes people can get away with this much stress before they're dealing with issues. Other times, it's going to be much smaller. The first thing that he has is a variation of anatomy, what's called Basilar or Basilar Invagination. What we've got here, if we're looking at the side of his neck, so here's his atlas, the top bone in the neck, and then here is his C2, and I've gone ahead and I've outlined it right here. It is essentially a peg that is going to allow for your head to be able to rotate. That is normal, but for some people that peg is ever so slightly longer. Again, in and of itself, it is not a problem. But what it does mean is it means that that little guy is going to sit much closer to the base of his skull and to the brainstem. This is a little line that I've illustrated here, what's called a McGregor's line. And normally, we would not expect for that little guy to project above that line by more than about 3 millimeters. The problem that we're seeing here is that, actually, excuse me, 3 millimeters, 5 millimeters, 5 millimeters. I got that wrong. But what I've done here, as you can see, not only is that projecting above it, it's projecting above by 7 millimeters. The result of that is that there is not as much functional space. Therefore, if he ever had a head or a neck injury, this area is essentially an Achilles heel. It's a weak spot. So that is going to be the spot where he would be most likely to experience symptoms. So we've already got that. But what he also has is a phenomenon that's known as a basilar kyphosis. So I'm going to switch over to the other view over here. And I need to mention something that we don't see on x-ray, and that is brain and spinal cord. So brain's going to be sitting on the inside of the head right through here, and the spinal cord is going to come down through the vertebra like this. Oftentimes, people think of the first curve of the spine as being in the neck, but the truth is that's not exactly accurate. The first curve of the central nervous system actually occurs right through here, where the base of the skull, represented by this line right here, is going to meet the upper part of the neck, and it's going to curve down like this. Now, for some people, that is very broad, very wide open. But other people, and this is what a basilar kyphosis is it's where it's a little bit more of an acute angle. It needs to make a sharper turn. So same thing. What that means, especially if a person is having their head put down into flexion like that, it's going to increase the amount of strain on the neural tissue right at that particular area. It's in that exact same spot where he already has a bit of that narrowness because of that basilar invagination. So one little thing plus one other little thing, not so good. And unfortunately, there's a third piece, and I think this is why the impacts that he's taken are the reason why it's so particularly bad for him. I had already mentioned this, that where he has a unfortunate decent amount of wear and tear is right down here between the C3 and the C4 vertebra. And even though the global arc of his neck curve looks relatively well preserved, functionally that's not quite the case, because as you can see, what I've done here with the lines is, even though he's got a good global curve, all of it is coming from just this one spot. In other words, it's not being evenly dispersed among all of the bones. It is a relatively straight line down to here, and then a relatively straight line down like that. And there's a particular action that's going to make that worse. That's going to be bringing the head back into extension. Now, what were his two injuries? Number one, having the trunk of the car hit him on the head. The other one, stepping off a curb, where again the neck goes like this. It extends at the neck, but then also shoves the head essentially down into flexion because of the jarring force. What that means is it means that there is a sharp zigzag that's happening right here through the lower part of the brain and through the lower part of his neck. In other words, it is producing a huge amount of pressure, huge amounts of irritation in that particular area. And unfortunately, it was just the wrong combination of his pre-existing anatomy with those two kinds of impacts that are making things much, much worse. And it's been tricky. He has little bits over the years done different forms of healthcare, little bits of chiropractic, little bits of physical therapy, little bits of massage. Some things seem to help out, but other things seem to really stir the pot. And honestly, he's in a bit of a tricky spot here, because I can look at this and say, there's not one magic little solution to this. This is more like his nervous system is stuck and he needs to unparallel park. And the problem is that he's only got this much room on either side. And if you try to do just one thing, you might be able to release one piece of it, but then you also have to do something else to slowly make the way out like this over a period of time. So this is a bit of a weird locked kind of position here, but seeing these little factors actually makes sense very much then for why he's experiencing what he is, but also why he's noticed that his neck and his head have been so finicky over a period of time. Now, these were the images that we took. We did also have a look at some MRI scans that he's had done. Let's jump at those. Okay, and I've put some pink arrows here to illustrate a few additional factors here. Now, the MR report said, and I quote, normal brain MRI. I repeat, no broken bones, no bleeding, no huge amounts of swelling. There was nothing like that. But there is another functional disrelationship that I can see here that should not be. And these are the kinds of things that often don't get reported. What it is it's an obstruction of one of his internal jugular veins. The internal jugular vein is the guy that when you are lying down is going to be draining blood and fluid from the brain back to the heart. So here we have it in a cross-slice image. I know this looks a little bit weird. Oh, and for perspective, this is the left side over here. This is the right side that's going to be over here. You might notice that on the right side, we've got a big open black vessel right here. But then you come over here and you see that that one is considerably smaller. It's not big and black, and it's not wide open by any stretch of the imagination. Now, oftentimes for people, their blood vessels are going to be a different size one side versus the other. But when we're looking at his other slices here, no, unfortunately what we're seeing is that this is not just a variation of anatomy. If we are looking here, down along the left side of his neck, this big black thing that we see right here is that same internal jugular vein. And right here, this is the tip of the C1 vertebra in the neck, and then here would be what's known as a styloid process. And as you can see, broad, stupidly narrow, and then it gets broad again. This is a sign of mechanical compression of the internal jugular vein. And this is oftentimes a factor of two things. Number one, a person has a TMJ issue. And the other thing is that a person has an upper neck misalignment. He had the whiplash injury, so that makes sense. And it didn't show up really on his MR scans here, but he also has a huge amounts of compression in his jaw. Again, that would have been something that would have been there for decades in him. But unfortunately, what I think is that the physical injuries that he's had, his body that had been able to compensate for that in the past, it's no longer able to do it. And the consequence of that now is that he actually is going to need a little bit of TMJ work with the neuromuscular dentist to create enough functional space to increase the bandwidth so that the other therapies that he would be having in terms of physical therapy, in terms of upper cervical care, are actually going to be able to work. In other words, and I told him this, is that I don't think that, I'm the primary portal of entry for him. I think I'm going to be playing more of a support role, but we got to get more functional space through here so that our kinds of care are actually going to be able to work the right way. The last image, this is again a front-on view. So here's the left side again, here's the right side. So right side, you see good space for that internal jugular vein. But right down through here, that looks a little bit, I think you would agree, wispy. This is what's called a motion artifact. And even though you don't see, you can still follow the black through there, but because it's looking wispy, that's telling me that this is not just narrow because of its normal anatomy, that there's turbulence of that fluid because it is hitting a constriction point as it's transmitting down. And sure enough, remember I said that's at the tip of the C1 vertebra. Well, here's that peg, so the C2. So atlas, C1 goes right across here. That point of compression is at the exact same point. So the combination of all of these little things is what I believe he has going on. And as much as I wish that I could tell him, yep, here's the magic adjustment that's going to fix everything, and then do your vestibular physical therapy, I think that these are going to be really important things for him. But he's going to need a few other things to set the stage first so that things are going to be able to work the right way. So, a bit of a case review here, but some interesting things that, again, when people have had whiplash, concussion, they've been to the specialist and they're told we're not seeing any pathology. It is sometimes the individual combinations of these little things that paints a far more accurate picture about what's actually going on. But number two, what needs to be done. I hope you guys have enjoyed watching this video. If you have, and if you haven't already done so, again, please click the like and subscribe. That way other people can find this video, and share this with friends and family if you think they'd benefit from it as well. Also, if you want some more information on the type of work we do in our practice, you can check out my other videos here on YouTube. You can also go over to our clinic website, clearchirospokane.com, where we've got a variety of different blogs, conditions that we can help people improve overall quality of life. Thanks for watching again. This is Dr. Jeffrey Hanna at Clear Chiropractic. Get well, live well, stay well. Till next time, take care.